you for your attention. My topic is about the high frame rate contrast enhanced US and the new technologies in interventional approaches in liver care. As said, since its introduction, contrast enhanced US has gained an important role in the diagnosis and in the management of abdominal and pelvic diseases. You can see a simple case of an hepatocellular deep hepatocellular carcinoma with the new Mindray technology. You can study in a very simple way the vascularization of this deep nodule. But contrast enhanced US can also improve lesion detection rate and can also help in interventional procedure much more than conventional US alone. And additionally, contrast enhanced US is able to show us the dynamic enhancement of different tissues and lesions without any adverse effects of contrast enhanced tomography or MRI. And so also in interventional field, it is a very important tool. EFSUM guidelines on interventional US say that local ablative procedures play a key role in the management of patients with malignancies, primarily with hepatocellular carcinoma, but also with metastases. And most operators, like me, use a percutaneous approach, but we can use also laparoscopic or laparotomic route. And we know that there are different methods developed and used clinically, like the old percutaneous ethanol injection, the thermal ablative procedures like radiofrequency thermal ablation, microwaves, and laser ablation, and recently new type of procedures like HIFU or electroporation. We know that the local ablative procedure can be classified according to the treatment intention as curative or palliative. Tumor ablation is usually performed with a curative intent, and this is true above all for a small ACC. Small means less than 5 centimeters, as well as colorectal liver metastases. The main indication for palliative treatment of liver tumors is metastatic neuroendocrine tumor load. So, what is I-frame contrast enhanced US? The concept, the idea is shown in this clip. Higher is the frequency of visualization. Higher are the frame rate of the clip. Better is the visualization of this sporting car. And some similar we have with this new technology that is inside the Resona 7. So, like in this case, in the first picture, this one, you can see the wings only not perfectly clear. In this second picture, with an I-frame photo, you can understand very well the wings of this bird. In this case, a simple case to understand the clinical utility of high frame rate contrast enhanced US, a small focal nodular hyperplasia, and you can see very well the microvascularization inside the nodule, and the microbubbles are very seen very well, and in comparison to the surrounding hepatic parenchyma. And you can really study the capillaries in this case, and you can study them in a real time. So in a pathologic field, it is important to study very well the nodules inside a cirrhotic patient and to understand if they are benign or malignant, and above all, if they are hepatocellular carcinoma or cholangiocarcinoma. In this case, we have two nodules on the mode and the color Doppler, but we can study very well this small nodule that has a part of arteriovenous shunt and a part of an active nodule. And with this new technology, you can understand very well, you can differentiate very well the two parts of the nodule. And here you can study the second nodule, the deep nodule. And with this new technology, you can see also in the deep part of the liver. But we saw in this case, we performed percutaneous ethanol injection of the small nodule and the radiofrequency thermal ablation of the deeper nodule. And after the procedure, we can control the effectiveness of the treatment, not with the color or B mode or color Doppler, but with the contrast enhanced CEUS. Here you can understand if nodule is efficiently treated or not. There is a vascularization because there is a arteriovenous shunt that can make impossible to understand if the nodule was treated or not. With high frame rate contrast enhanced CEUS, you clearly see that the arteriovenous shunt is alive, if I can say, is active, while the nodule near to this shunt is efficiently treated. Another case, a small nodule, a small hypoechoic nodule, color Doppler is not useful to understand if this is a small hepatocellular carcinoma or not. And so we can perform contrast enhanced CEUS. And here, spiral CT was negative, okay? But here you can see the hypervascularization in the early arterial phase, the vascularization that is homogeneous with the other hepatic parenchyma during late arterial, portal, and late phase. And only in the ultra late, we can say, phase, the nodule become hypovascular. So we performed, to be sure, the FNA, and the diagnosis was well differentiated small hepatocellular carcinoma. I remember you that this nodule was invisible also to spiral CT. So we performed radiofrequency thermal ablation on this small nodule. Okay. I want to show you that with the Mindray technology, the radiofrequency doesn't obscure the image. So here the nodule, the needle is active, as you can see here. This is the microbubbles, the gas obtained by the radiofrequency. But you can see that all the image is nice and very visible also during radiofrequency thermal ablation. And we thereafter performed the control with conventional US here, and with a color Doppler. Here you can understand if nodule is efficaciously treated or not, obviously. And here with 1 milliliter of sonoview, we can understand that nodule is efficaciously treated, and also that we have obtained the safe halo. Other examples of an hepatocellular carcinoma that was superficial, that was treated in an 80 years old patient, was treated with a transarterial chemembolization. 1 month after, we tried to understand if the nodule was also active or not. The nodule is in a strange position, so wasn't treatable with radiofrequency thermal ablation, because this is the gallbladder. And after transarterial chemembolization with only 1 milliliter of sonoview, we can easily understand that the nodule wasn't completely treated, that there was a real, also an active part in this, in the part of the nodule near to the gallbladder. This nodule was completed with percutaneous ethanol injection. And this treatment was performed based on this examination and not on spiral CT that was negative for tumor. In the second part of this topic, we speak about fusion imaging in the interventional hepatic approach. We know that fusion imaging is defined as overlaying of images from the same or different images modalities. So incorporating ultrasound imaging with spiral CT, MRI images is useful because we have the possibility of comparing findings on one modality with another one. So ultrasound is a real-time image method. Spiral CT, MRI, PET are high resolution and panoramic images, so they are important. Using fusion images, we can obtain the advantages of both the methods. There is one problem. The breathing determines a rotor translation of liver that can lead to a mismatch of a considerable size. And this was already known in the past and was said also in literature. And we also performed a study with a new system of Mandre, in which respiration compensation was the system of respiration compensation was studied to understand that this new method was able to correct the mistaken performed by respiration. What does it mean? You can see on the right spiral CT that is still, while patient is breathing, so liver is moving, while spiral CT image doesn't move. But with this new technology, we are able to move in real time the image of spiral CT, in this case of MRI, of other methods. And this in this way, we can use ultrasound and the other images for intervention purpose in a better way. So fusion imaging can be used, for instance, to better study a small lesion that are not so evaluable with the conventional US, and that are difficult to study, like this small hepatocellular carcinoma that was very superficial and was not visible on conventional US. So what can guide contrast analysis US? In this case, the guiding image is an MRI, and you can see here also some markers that give you the precise idea of where is the lesion in the MRI and the corresponding position of the lesion on contrast analysis US. And this is very important in several cases, like you can see after. We can use also dual mode, so conventional US, contrast analysis US, and other techniques like MRI, and we can easily visualize the lesion on different types of imaging for better diagnostics confidence. So we can use fusion imaging in pre-procedural imaging assessment. The major indications are sonographically undetectable lesion, large lesion only partially visible with the US, but also the so-called electro disappearance on US during ablation. You have seen that with the Mindray system is not real, fortunately, and also we can use fusion imaging to study lesion adjacent to risk anatomical structures or lesions requiring multiple insertions. So we can see just some example of the first two major indications. Okay, this is the lesion before. Okay, so it's not too simple to understand also with the contrast analysis US. Understand where is the lesion, but we can put here inside the needle, and to perform this, we can use fusion imaging that guide the nodule inside the lesion. Sorry, another case in which a big nodule, but you see the nodule all, just in this part, because there is air, and so with a conventional contrast analysis, we are not so able to understand what happened here. So you can superpose the two modalities images to understand well the nature of this nodule, and to understand how to enter the needle inside the nodule. This is called the interventional planning. In this case, you see two rings. The first one is the nodule. The second one is the so-called safety halo, and that means that the optimal treatment option for the patient, and so you can understand how and where to put the nodule to perform the best procedure. In fact, this is the case that we have seen before. Here you can see the nodule only in a small portion, and this you can see the nodule, the needle that is guided inside the nodule by these two rings. This is very easy with this guidance system. And several years ago, several authors demonstrated that some ACC patients showed local tumor progression a few months after first ablation because of these residual tumors that was unnoticed on axial images. So this system is able to help us to perform a complete treatment in a very easy system. And another case is a lesion difficult to puncture and to treat. So here you are not able to understand if the nodule is only this or is here, but the MRI is able to guide, the MRI reconstruction is able to guide you to perform the correct procedure and to treat exactly the nodule and to create also a safety halo that can make this treatment very efficacious. And also in the treatment monitoring, fusion system is quite useful. This is the nodule that we have seen before. After the procedure, we can compare two images to understand that the ablative margin is good, and we can say in an easy way that a safety halo was obtained. At least we can, I want to show you a study performed with the Mandray fusion system that was published last year on the International Journal of Hyperthermia, in which the authors demonstrated that fusion imaging with 3D CEUS in comparison with 3D spiral CT was able to detect the safety halo and to treat in an efficacious way this nodule, and in a more precise way in comparison to spiral CT. These are the images of the paper. I don't want to comment this paper, but just to give you an idea. And this is the rock curve, in which you can see that an ablation margin less than 5 millimeters give much more new ACC, local ACC in comparison with ablation margin of more than 5 millimeters. So this aspect of the safety halo is very, very important. So how can I use this system to understand if the safety margin is really reached? This is the nodule that you have seen before. This is the control with the contrast enhanced US in comparison to MRI, and you can see that here you have obtained a really good result. So you can say that this nodule was efficiently treated. Another case in which you can superimpose the MRI image before the lesion, the treatment, and the contrast enhanced US after the lesion. And we can say that this clip doesn't need any more words. So also in this case, in a few seconds, you can say that we have obtained a safety halo, and we can say that this nodule was efficaciously treated. And with this last slide, I thank you for your kind attention.